Hi everybody, welcome to this ASCOT webinar, the last in our series celebrating ASCOT's 10th birthday, if you like. Today's session is going to be an hour long. We're going to have a joint presentation by Professor Anne Natton, who founded the ASCOT work, and I, which we will start in a minute. I can see that more people are joining as I'm doing this introduction. I'll just do a little bit of housekeeping before we begin. Please keep yourselves muted during the presentation. There will be an opportunity for Q&A at the end. If you think of any questions for Anne while she's talking, you can either save them up and we will invite you to raise your hand at the end, or you can use the chat function. On Zoom, this is at the bottom of your screen and you should see a box saying chat. And if you click on that, you should be able to open it up, introduce yourself to the group and type any questions. And Lizzie will be keeping an eye on that, as will I, as we go through the session. And we will hopefully have time to go through all those questions at the end. We've got an international audience today, so it's really nice to also use this as an opportunity for networking, which is why I'm trying to encourage everybody to sort of type their names and maybe where they're from in the chat. It's just nice for people to get to know other people who are in the call. Other than that, I don't think I need to say much more other than just to crack on. And yeah, over to you, Anne.
Thank you very much, Anne-Marie. Okay, so the impetus for this particular webinar came from Birgit Trukashitz, who felt it'd be good to have a webinar on ASCOT, how it began, looking at decisions made, domains considered, the scale, how it became a toolkit rather than a single instrument. And in trying to put this presentation together, it quickly became clear it's complicated. Initial development took over 10 years and a number of overlapping projects. And one thing that became evident in thinking about how it developed was it was driven by a number of influences from research, policy, and latterly practice. Sorry, finding my way in Zoom, apologies. Okay, so the context for the initial piece of work that was undertaken, I'll start with talking about, and then as we go through, talk about the changing world of social care policy and practice, and then look at the research response, both in terms of what was funded and what we did, the key projects and their contributions. And then I'll hand over to Anne-Marie, who'll talk about the further developments and take-home messages. It's quite scary to think that this project, this work, all started in the previous century. So in the 1980s and 1990s, social care in England, there were a lot of changes being undertaken. I haven't even mentioned here the shift from institutional to community care services. Amongst older people, there's a big emphasis on using care management for complex packages of care. There's a shift from low-level services to targeting on people with higher levels of need. And in provision of services, there was a move to private companies rather than the local authorities providing the services. And through all this period of change, there was a lack of any specific measures or monitoring of what was going on. And this was in contrast with healthcare, which has always been much more research focused and is closely linked to social care. In the health services, clinical trials are frequently used, and cost effectiveness at that period was becoming an important issue, and looking at comparing across different types of healthcare intervention. So in healthcare, the development of the EQ5D and health-related quality of life was coming up as an issue, and there was an increasing use of an influence of quality-adjusted life years. So I don't want to give the impression that nothing was happening in social care. We were measuring in the individual research projects the effects of these type of interventions, but we were using generalised measures such as quality of life or activities of daily living. And one of the bees I had in my bonnet was, are we actually drawing the right conclusion from evaluations sometimes? Because you might find no effect with a quantitative measure, whereas qualitative work has indicated that something really did seem to be going on. There are particular challenges in measuring social care outcomes, though. There's this ongoing and often increasing levels of impairment. where social care is compensating rather than affecting levels of impairment. And the full benefit of interventions is rarely reflected in a before and after approach. You're catching people along their social care journey. Often carers have been involved early on, they may drop out, they may come in, and they play a very critical role in the provision of social care and also are receivers of the benefits of social care. In addition to these specific issues in terms of measuring social care outcomes, you've got trying to gather the information when you've got a high proportion of service users with cognitive impairment and or communication difficulties. So the first project that we undertook was called OPUS, or the Older Persons Utility Scale, and I'll be talking about that in some depth in a minute. Then there were a series of studies which were fed into the user and carer experience surveys, which were important in our development of ASCOT. Measuring outputs of public service users, or MOPSU project, was brought on by interests from the Office of National Statistics, and the quality measurement framework then led on from that work. And you can see from the dates, there's a lot of overlap in the timing of these projects, and that was an important influence in the development of ASCOT. OSCAR, developing a measure for outcomes of social care for adults, was the project which actually developed the final scale. So I'll talk a little bit about that. And then the first international study was the EXELC study, which started in 2015. So I want to talk about the OPUS study as, if you like, the origins of ASCOT. This was funded by the Department of Health as part of a programme of research on outcomes of social care for adults, the first one that was undertaken in this country. And the key objectives of the OPUS study was to reflect the impact of interventions of services for older people and to have a preference-weighted measure, an equivalent to the health-related quality of life measure of EQ5D. And in developing this measure, a key question was, what is social care actually aiming to do? We know it's looking at quality of life, but what aspects of quality of life, what is social care actually doing? And this was tested then. Our conclusions were tested with older people and care managers. So it's a different approach than is often used in measuring, developing measures. Now, a key issue that arose really early on was that the thing that people would say most that they wanted from services was independence. A lot of people don't want services in the first place. And what independence meant depended very much on your situation, whether you were living at home, living in a care home, or whatever. So what actually meant by independence, the same word would be used, but it would actually mean very different things in different contexts. But what we found was that underlying this was this sense of control over what was going on in your life, control over your daily life. That is how people were actually meaning the word of independence. So control was a very, very early domain to be developed. At this point, we were very much trying to focus it on what social care was doing. And as I've said, from policy point of view, for older people, whereas in the past, household cleanliness had been an objective of services, you get people coming in and doing housework, that was being abandoned with this function, with this emphasis on higher level needs and personal care. And in services such as daycare, the main emphasis was on reducing social isolation rather than actual occupation. Another issue that came up was conflicting perspectives. Whose view? Individuals or the family or care staff could actually report very different need states than each other. And we've actually found in our work a very low correlation between care managers and what individuals themselves felt were going on. So that was something that we wanted to be able to reflect in our measure. The measure also developed from or used the Camberwell assessment of need, a particular version for older people. And this was had two elements to each question. We would identify, is there a need? And if there is a need, is it met? For Opus, we turned this on its head and said, right, okay, what is your situation? And then in the absence of the services that you are getting, what would your situation be? And we found this did work in the context of social care. So the end measure was a control over, had 5 domains: control over daily living, safety, personal care, food and drink, and social participation involvement, and you'll recognise those from ASCOT. At this point, we had 3 levels: high-level needs, low needs, and all needs were met. And it was scaled between 0 and 1. It was preference weighted by our study. The instrument itself allowed completion from different perspectives. So service users could complete it for themselves. You could put alongside that what carers thought were going on, and that's unpaid carers. And then you could have care managers or care staff completing it. So you could get all 3 perspectives if you wanted. And the idea was to be able to make that comparison as part of a research project if wanted. Each domain we thought through quite carefully at the time, and there was a point at which we said we ought to have a philosopher on our research team, because when you started to think about domains such as safety, that's really not straightforward. Do we mean people are really safe, or do we mean they feel safe? And who says they are safe? Is it the carer, who will often have a very different version to the individual? So we included in the measure an objective risk to be reflected through a list of events, such as had they had a fall in the last few months, or had they left the gas on or set fire to things, the sort of things that people were often worried about for older people, and older people often weren't worried about for themselves. The expected level we found did work, and we had initial evidence of validity. So that was where that first instrument looked. So we came out with our OPUS measure, but didn't actually get much demand once it was actually out there in the wild world. Partly may have been lack of promotion from us, but it really didn't get picked up by research. However, in the field of social care policy, this emphasis on how can we measure outcomes, what's actually working in terms of what we're doing, where are we falling short, are we actually improving what we're doing, and where is doing better, particularly from the Department of Health's point of view, wanting to look across different local authorities. And they started to introduce the user equivalent to patient experience surveys, which were already working in health. And alongside this, there was this need for performance indicators. Can we just see how things are changing over time and how they compare? This was in a wider context of an increased emphasis on productivity and efficiency overall, and particularly in public services. And as I mentioned earlier, the Office of National Statistics were interested in reflecting the value of public services in national accounts. At this point, if you tried to measure productivity, about which we hear quite a lot in the news these days, inputs were measured the same as outputs when you looked at public services, so you could never see any difference in productivity. The user experience surveys, as I said, as they were introduced, were a very important driver for the development of ASCOT. The initial focus of the surveys was very much on process. This was something that local authorities were very much in favour of because they were easier to measure and important and informative in improving the quality of services. So the sort of measure I'm thinking of is things like, are your care workers on time? Do you see the same people? And so on. But when you start to try and make any comparisons across different interventions, that is very specific to the type of service. And it was also found that when you start to look at looking at performance indicators, if you start using that kind of measure as an indicator for performance, then everybody focuses on that measure. So is it actually affecting what happens to people? What we actually want to know is, are people's lives getting better, not whether the services are improving lateness or whatever. So there's very much a need to include outcome indicators, ideally as part of performance. Problems were also identified. The first surveys focused on older people and using the questions that were used with older people for younger service user groups. So we undertook a number of development studies to test the performance indicators and to test and pilot items for the younger adults user experience survey. So we started with our existing OPUS domains and then looked to extend them and develop and test the items themselves and the way the wording was working. This was undertaken through interviews and focus groups with younger adults. So there were extensions to the 2003 and 4 and 5, 6 home care surveys. And also the carers survey. That's where the carer version of ASCOT developed through the development of the survey for carers. The idea being to link what ASCOT domains as far as possible but for service users themselves with carers, so we could make comparisons where it was sensible. Alongside this, as you saw earlier, these things were going along in parallel. There was this study which was looking at measuring outputs of public service users. As I said, the idea was to try and reflect the value of social care services for the purpose of national accounts. So the piece of work that we undertook was largely a literature and theoretical exercise to define and measure the social care outputs. But this fed into and drew on the user experience development study. And one of the things that emerged from this piece of work was this concept of capacity for benefit, as we found the validity of the expected measure was being reflected in a correlation between ADLs, which are easier to measure, activities of daily living, and expected levels. We found that correlation, which is useful for the purposes of actually ongoing monitoring. So we had these ongoing different pieces of work, which then we emerged from this a wider version of our outcome measure, which we now started to call ASCOT. We have got the opus domains, so we included now occupation, because that was important for younger adults, accommodation and cleanliness and comfort, which is what their services were also including. And we identified the measure of caring for others, which was one of the things younger adults wanted to be able to do and to be able to facilitate it. We also identified the issue of living in your own home. Quite often people say, I want to stay in my own home. This is true of older people as well. But we didn't have this as an ordinary domain. We kept this just, are you living in your own home, yes or no? And at this stage, we had 4 levels. There is no problem in my life in this area. Services meet my needs. There are some unmet needs, and there's high unmet needs. And again, as I say, there was the ASCOT carer measure that was developed as well. Okay, so context moves on and we actually get more changes, and we've got now much more emphasis on personalisation, reflecting service views and aspirations, and allowing them much more control of what sort of services they have. With the introduction of an initiative called individual budgets, where people themselves could decide how to spend the money that was allocated to them for the purposes of social care. And we were involved in the evaluation of that initiative and used the 3-level version of ASCOT with the domains I've just gone through, used in the evaluation. The other issue that was coming up was excluded groups and user experience surveys. Who aren't we getting properly? In particular, there was an issue around care home residents, where although the survey might be sent to them, who was actually filling it in and how validated were the views that were actually being reflected. And social care related quality of life, there was much more emphasis now on supporting carers and how could we reflect that. And also we've got the ongoing issue of measuring outputs for national accounts. So the quality measurement framework was funded by the Office of National Statistics, and it built on our previous work, the MOPSU work, and that included 4 studies, one setting care homes, another low-level services, one looking at information advice, and a preference study for the updated version of ASCOT. The big influence on how ASCOT developed further was particularly through the care homes work. Here we started to try and really include people with cognitive impairment in a care home setting, and introduced this idea of a mixed methods approach, drawing on observational expertise. And I do particularly want to mention Julie Beadle-Brown, who played a key role, drawing on her expertise in the field of people with learning disabilities. We wondered whether it was actually possible to include the idea of expected in a care home setting. So we wanted to try that out. But in using the mixed methods, we discovered a wealth of qualitative data that was actually produced. Clearly, this was not something people could just pick up easily and start to use, so we needed to introduce the concept of training. And it was as we started to talk about this with various people and hold workshops, the practice implications of the work really started to come through. We've got vivid memories of somebody turning up, they picked up from the website, and I do want to mention that website, because if ONS had not insisted on a website, I'm not sure ASCOT would have developed the way it did. They wanted us to have one, and it has to be said, it's the sort of thing researchers don't get around to, but we did. And as a result of that, people were picking up the measure well before we really were ready for them in some ways. And they were actually just going out and using it without any training and then feeding back to us. And we started to realise some real practice implications of the work we were getting. So the Outcomes of Social Care for Adults project, or OSCAR project, was, if you like, from my point of view, quite an important sort of tying up project from the previous work. It was funded by the National Institute for Health Research Health Technology Assessment Programme. And at this point, the research drivers were the main thing. We wanted to finalise and validate the measure we were getting was being picked up. And we wanted to validate that expected approach so people could often express doubts about it, but actually it really does work. And we wanted to get our final preference weighting for this social care related quality of life measure and actually develop a QOL, which requires it being anchored to the death state. So we wanted to get that kind of a measure to the scale. And we wanted to validate the preference weightings. Do service users actually think the same about these different domains as the general population who we'd always surveyed in the past? This work ran in parallel with the Quality Measurement Framework project, which I've been talking about before. And all this work facilitated further testing and comparisons with what was coming out. So the key aspects are that we ended up with our final interview and self-completion instruments. We tested all the domains and items. We validated the expected approach. And in the process of all this work, rejected some of the domains that had crept in, doesn't feel like the right word, that we've been using. Living in your own home, we identified as actually was really, all the impact was actually reflected in the other domains. There is that residual thing, but I don't think it's worth a separate domain. And the caring role really didn't apply to enough respondents for it to be included as a part of the main scale. But we did include a new domain, which was dignity, which was very much about the process of social care, because once you are receiving social care, this is another aspect of your quality of life, and how it makes you feel is something that is relevant as an outcome. And this is where we started to tie the levels of the responses to the capability and function level. So our response options for each question, we'd see needs as a functioning. So you had high needs, we've got health implications. But ultimately, with many domains, if don't get enough food and drink, you'll die. And we've heard horror stories of that sort of thing happening. If you've got some needs, there's no health implications, but that's important to you. And then in the absence of need, we go for the no needs, mustn't grumble, still at a functioning level, and preferred situation, aspirations, reflecting capability, where I want to be. And these are our final domains with which I expect you're all familiar. So we've got the personal cleanliness and comfort, food and drink safety, clean and comfortable accommodation as our basic domains, higher order, social participation, involvement, control over daily living and occupation, and as I say, that process impact domain of dignity. I want to talk very briefly about the preference studies which were going alongside all of these pieces of work. Our initial preference study for Opus addressed one of the questions which came up, which was what's more important to people, control or safety, that trade-off. That was something which became quite an issue in the early work. And we found that, as I will show you shortly, it's consistently you get control is more important to people than safety. And this was shown consistently in all subsequent studies. And in fact, one of the things that's been a very positive result of this work is that the preference studies work we found over time in the English population, a variety of different techniques, different ways, essentially you get the same sorts of results. We're pretty confident in our preference weightings. The pilot study for MOPSU actually anchored to a financial attribute. As you will remember, there was a point in which efficiency was a dominant thing in what social policy in particular. And one of the things that people wanted to be able to do was to measure outcomes on a financial basis. So this is what it costs, and this is the financial value of that outcome. So we got one. Nobody wanted to use it because it basically meant that the value was always more than the cost, and they didn't know how to use that. Living in your own home, I found interesting, was linked to socioeconomic group. It was important to all groups except those in the lowest socioeconomic group. The Oscar project allowed us to compare the general population with service user preferences and to anchor to being dead. And we were glad to see that general population service user preferences were the same, so we could carry on confidently using our preference weights without having an issue about which sort should we use. Just briefly want to take you through what the results are. In this particular figure, you can see that the actual weights are linked to the control domain, which, as I say, dominates in the English population. And we've got 0 for the highest level of needs and control, and 1 for, and all of these other levels are weighted to that. So 1 for the highest aspiration in terms of control. So you can see here the safety, which I was talking about before. It is actually the lowest level of domain compared to all the others at the high level needs, but it is more than we have got for the control. And it's interesting to see that one of the most important things in terms of one's aspiration is occupation. You can spend ages on these slides looking at the differences. It's quite fascinating. So I'm going to hand over to Anne-Marie in a second here, but just to show you where we've got to, we've got the final ASCOT measure here at the end in 2012. And these are the projects that I've been talking up to date. And you can see that important, complicated as it was, it's nothing compared to what's going on. So I want to be able to hand over to Anne-Marie now.
Thanks, Anne. Indeed, very complex. So hi, everybody. I'm just going to take you forwards now. So looking back to where Anne left off around 2012, which was on the launch of the ASCOT measure, the final preference weighted measure, which is where this idea for doing a webinar all came around, because we started planning this back in around 2022-23 and started this webinar series, recognising it had been roughly 10 years since the launch of that preference weighted measure. We wanted to mark that in some way. But as you can see from this timeline, which by the way is only for the service user measures, the carer measures, there has been so much work around that, mostly led by my colleague Stacey Rand, that it's going to have its own timeline, which we're developing at the moment. So just focusing exclusively on those service user measures, you can just see to the right hand side of this graph, of this chart, just how much activity has been underway since that official launch. And hopefully this gives you an overview of both the research studies which have underpinned that work at the bottom of the timeline, and at the top of the timeline, some of those kind of policy pressures and what was sitting underneath it. So what were we trying to achieve with the work going forwards? And I'm sure you can also see an awful lot of international work. So if you can move on to the next slide, Anne, I'll talk a little bit about that in detail. So some of these policy and practice drivers post 2012 were around, for a start, an increasing rise in the profile of social care. That has, I think, been exponentially increased in the last decade. And this has really been a global thing. So we've seen a huge increase in demand for translations of the measures and interest in making international comparisons. And I'll talk a little bit more about that in a moment. Anne mentioned that very early on, there were some clear indicators that there was a practice element to these tools, but that was a little bit slow in the uptake. But certainly in the last 10 years, we've seen an increase in this. So how can the tools be used in quality assurance, maybe in monitoring, and more recently, and of particular interest to me, around care planning? And then finally, we recognised that having developed the ASCOT measures, self-completion tools, so the interview and the SCT4, which is sent out as a survey, we realised that some groups were being systematically excluded. So in particular, people with learning disabilities and people with dementia living at home. We'd done that work around care homes that Anne described, but we hadn't thought about how we would capture people who have increasing needs in their own homes in the community. How do we give them a voice and ensure that their outcomes are being met? Next slide, please. So just want to mention the work that was undertaken as part of one of the policy research units, Quality and Outcomes of Person-Centred Care, which is led by Professor Julian Forder. And there was a series of studies within that 5-year policy research unit programme of work led by my colleagues. And if I start name checking, I'm going to miss people, but you can take a look at our website and see all the papers, the references around this work. But particularly, I want to mention James Cales and Stacey Rand, who were involved heavily in both the Easy Read, the proxy, and the ASCOT carers. So as you can see, this was really about how do we increase self-report? So an Easy Read was developed with adults with intellectual disabilities and autism, and this included the use of pictures, simplified language, smiley faces next to those response options to help guide people to the right response option for them. An ASCOT proxy measure, which similar to the very early Opus measure, looked at kind of different perspectives of people's quality of life rated by somebody else. And in particular, we have two side-by-side columns, one which is asking the proxy to give their own view, and one which is asking them to give the view of what they think that person feels, who they're answering on behalf of. Which is quite nice because it means you can compare those two different perspectives. And then, of course, the ASCOT carer work. So whereas we'd had an early measure of carer, social care related quality of life, which had been used in surveys, it was similar to the development of the ASCOT. It was 3 outcome states per domain, and we wanted to extend that to 4 outcome states. And we also wanted an equivalent way of measuring impact of services on the outcomes of carers. And so the work within QOL also developed the expected scale for the ASCOT carer, which you can now see on our website as an interview, exactly the same as we've got for people who are drawing on care and support themselves. Next slide, please. And then, as I mentioned, in 2015, there was the first really truly international research project exploring comparative effectiveness and efficiency in long-term care. I wasn't part of this project, so please forgive me. I'm just giving an overview on behalf of our colleagues. What this essentially did was validate ASCOT instruments in 2 European countries, Austria and Finland. And if you go to our ASCOT website, you can navigate to these international pages, and there are links to websites and tools in those languages. And really importantly, it also developed English preference weights for the ASCOT carer tools, which hadn't existed previously. So we'd done that extra development, but we didn't have preference weights. So really built on the work that was being undertaken within QOL. And fantastically, we also got preference weights for German and Finnish ASCOT and ASCOT carer measures. And this is brilliant because it allows us to start thinking about comparisons across countries. So our first international comparative study. Next slide, please. And this slide is just to give you, I haven't got time to go into the detail of all the different countries, but I just wanted to give an overview of the different languages that ASCOT is being translated into, both the ASCOT and the ASCOT carer, which, as you can see, has really boomed in the last 10 years. And it's brilliant. It's so exciting to see. And as you can imagine from the work that Anne's already presented, for each country is going through its own journey of translating the measures, validating those measures, hopefully in some cases developing their own preference weights. These are not short bits of work. These are big programs of work, and sometimes they're being developed over a number of years with different funders in each of those countries, and sometimes by different teams who are building on each other's work. Wherever possible, what we're trying to do with ASCOT is identify in-country leads for ASCOT. So we already have an Austrian team led by Dr. Birgit Trugschitz, and we have a Finnish team led by Professor Ismail Mosa, and we're going to be having teams in all of the other countries as well. That's the plan. So quite exciting and brilliant to see that work ongoing. Next slide, please. So sort of reflecting on ASCOT's strengths, I suppose, but also some of the challenges. Where we are now with ASCOT is that we're able to look back, this is in England, we're able to look back and think, okay, it's a measure that's being recommended by the National Institute for Clinical Excellence in England. Its preference weights reflect population and people drawing on care and support, their preferences. We know that it works as a way of assessing the impact of services, so a considerable strength. And partly we've been able to do this by looking at that expected measure that Anne was describing earlier. That's what makes ASCOT, I think, significantly different from other quality of life measures, is that we have this hypothetical or expected measure. We've developed a variety of different methods and measures. It's really now a suite of measures rather than a single measure. And the aim behind that was to allow the inclusion of hard to reach groups or seldom heard groups. And we've also developed the ASCOT carer measures, which allow us to look at different outcomes for care dyads and think about the impact of services that are aimed at carers, which is moving higher and higher up the policy agenda, as it should be. Next slide. So where are we now with our work in England? So we're now thinking about other applications and developments for the ASCOT programme of work. ASCOT is being piloted as part of the DATCHA study, which is led by the University of Hertfordshire. I co-lead the final work package, which was piloting a minimum data set for care homes, and ASCOT is included in that minimum data set. It's been quite exciting because what we've been able to do as part of that work is include the ASCOT proxy measure in digital social care records. So just like care staff complete health measures about residents living in care homes, for example, their skin integrity, pain, hydration levels, and so on, they also can complete a measure of care-related quality of life using the ASCOT proxy, and it sits within those participating care homes in their digital social care record. So something that is routinely reviewed and collected in the same way as health data would be within care homes. And that work is currently being analysed at the moment, and we've been looking at psychometric properties. A paper has just been published on that in 2024, so we'll put that, make sure that's on our website for those of you who are interested. And I'm pleased to report that psychometrically the measure seems to be behaving well in digital social care records, even though it's being completed by staff. But because we used the ASCOT proxy, we had those two different measures side by side. So the staff's own perspective and their view of what the resident feels. And what's been really interesting from the analysis that my colleague Stacey Rand has done is that it's clear that the best proxy measure to use is the resident's own perspective. So where the care staff are basically rating on behalf of the resident rather than giving their own view. We've also seen a massive increase in use in care planning by providers. And as part of this webinar series, we'd already had a whole webinar on that. So you can access that through the resources on our website if you're interested in finding out more about that. But particularly this work started in Australia with the Widden Group, and now Attendo in Sweden are using it and are rolling it out not only in their nursing homes, but also interested in using it in home care as well. And my colleague Nick Smith, who's on the call today, would be able to answer questions about how we're starting to use this in England as well. And we're doing some work funded through the NIHR Applied Research Collaboration in Kent, Surrey and Sussex. And that's quite exciting. We're also doing some individual work with providers in the UK. So hopefully a growth area. And I think this is really important and really key if we want to get quality of life sort of as part of routine data collection. One of the things that we have been consistently asked for since the ASCOT Easy Read for adults with learning disabilities and autism was developed is an equivalent measure, but for older people, particularly those living in their own homes with dementia. And I'm really pleased to report that I've been leading a study funded by the Research for Social Care for the last 2 years, looking at this, and with my colleague James Kales and Raza Mikalita at the CHSS, and we have developed a lovely easy read for older people, which will be available in May 2024. Dr. Stacey Rand has run the psychometrics on that. Sorry, not psychometrics, has been looking at the analysis for that. We've got a beta version, so everything up to the psychometrics, and that will be something that we'll be looking at going forwards. And that will be available for people to use from around May of this year. Last 2 points just around wider applications. So the UK Health Security Agency has recognised following the pandemic the need to start looking at the impact of things like infection control measures and infections themselves on the quality of life of people living in vulnerable settings. And some of those vulnerable settings are really important to social care, for example, care homes. So we're currently doing some work with colleagues at UEA, funded by the UK HSA, looking at the feasibility of using ASCOT to capture the impact of infection control measures on people's quality of life in those settings. And you can imagine there's lots of overlay here with things like how providers might be using it, about the work with DATCHA, where it might be embedded in routine data collection and digital social care records. So lots of overlaps, but looking at it very specifically within that context. So is ASCOT sensitive to the impact of infection control measures such as isolation, um, you know, vaccination, um, the types of things that would be ongoing in care homes to stop the spread of infection. Really important since COVID. I don't think I probably need to explain why there's been a real boom of interest in this. And finally, and it's a slightly different direction, I've been leading some work to develop a new ASCOT measure which specifically looks at the work-related quality of life of the social care workforce. And I'm just going to say a little bit more about that before I close and we go to Q&A. So if you can move on to the next slide, please, Anne. So Department of Health and Social Care, I think, have really recognised over the last few years the importance of employee wellbeing. And we have a workforce crisis in this country, and I don't think it's only in the UK. This is something that we're seeing across Europe and wider around retention, recruitment, and having a workforce that's able to meet the needs of the long-term care population. We were funded along with Ipsos and Skills for Care, who are the workforce development organisation for the social care sector, to undertake a national social care employee wellbeing survey. And as part of that, the team at the University of Kent have developed an ASCOT workforce measure of care work related quality of life. This is built on previous research that we've undertaken here at Kent, including a rapid review and qualitative work with the workforce. And the idea behind this measure is that we'll capture the aspects of a person's quality of life most impacted by working in social care. So it takes into account some of the specific challenges and impact of working in a caring role. It is designed to go across the workforce, so not just about care workers, but also about social workers, nurses working in social care, occupational therapists working in social care, management roles, anyone who's working directly in a care role within the social care sector. The domains and the wording have already been now tested with the workforce. We've taken the ASCOT framework across. So there are domains, and for each domain, there are 4 response options relating to outcome states, reflecting those 4 levels of need that Anne took you through earlier that you'll be familiar with all of the with all of the ASCOT tools. It's not preference weighted yet, but it can be scored from a value of 0 to 39 being the highest possible work-related quality of life. I'm just going to give you a little overview of the domains. If you go on to the next slide, please. So it's longer than the other ASCOT measures. There are 13 domains, which you can see there, listed there. And I think anyone that's spoken to anyone working in the social care workforce will recognise the value these domains. So people told us that the reason that they work in social care is they want to make a difference. And one of the reasons that they exit the workforce is because they feel like sometimes that the time they're given, maybe the funding that's available to support people, means that they don't feel they're making a difference to people's lives. So this is really important, and it's a driving factor as to why people leave. Relationships with the people that they're supporting. This is essentially everything that we do in long-term care or social care is about relationships. It's absolutely vital. Having some opportunity to have autonomy over your role. So you're a home care worker or you're a social worker, you've got a person that you're working with, you need to be able to make in the moment decisions and feel that you've got the autonomy to do that if you're going to be delivering high quality of care. They recognise the importance of having time to care, so not feeling like they're rushing people, but they've got the time to give people the care that they deserve. Worrying about work, so going home after hours and thinking about the people that you're caring for and the strain that that can place on individuals. Having time to self-care. Can you take a break? Can you eat and drink in your shift? Feeling safe in your caring role. Professional relationships, so relationships with colleagues, but also relationships with health. So if you're a care home manager, how are your relationships with the local GP, with the community nursing team, and so on? Feeling supported in your role. So this is about sort of line management, supervision by your employer. Do you feel that you've got the support that you need? And importantly, do you have the skills? So this is competency. And also thinking more about a career pathway, something that's been lacking in a lot of social care roles and is something that is a real policy priority. So do you see yourself being able to move up the ladder and have a career in social care? Financial security, we know this is a low paid sector, so something that's really important to households. And finally, feeling valued. Something that the pandemic really shone a light on was that health colleagues, we had all that clap for carers, but that came a long time after clapping for the NHS. So the importance of feeling valued in your social care role. Next slide, please. This was included in a survey of the workforce last year, and we had an incredible response, over 7,000 responses across the sector. Um, and we've been able to look at psychometric properties of this new scale, and a paper on this will be out soon. So I'm pleased to say that the psychometric properties are all acceptable through to very good. I won't go through all the technical detail because I'm conscious of time, but you can have a look at that on the slide. The good news is it seems to be forming a unidimensional scale similar to all the other ASCOT measures. It responds in the way that we would expect it to in terms of its relationships with other measures, and its internal consistency is very good, which means that the scale seems to be hanging together and working well. I've put a little point here that we do need to do some further subgroup analysis. So we will be looking at that around, is it working well for every subgroup within that workforce population? So is it working well for nurses, occupational therapists, social workers? Preliminary results seem to be that it is, but that's something that we want to do a little bit further analysis around. Next slide, please. So just to wrap up, in terms of the workforce measure, second wave of data collection will be happening this summer. And the report on the wave one findings that Ipsos Murray are leading with Skills for Care in the University of Kent should be out soon. That's with the HSC at the moment. We're planning at the University of Kent to lead a paper on the ASCOT workforce measure, just that, and its psychometrics, which hopefully will be out by summer 2024. And at that point, the measure will be made available on our website for wider use. And sort of thinking about how we might use a measure like this, we're certainly going to be looking at doing some multivariate analysis to answer priority research and policy questions. It's a huge data set, and we've now got this incredible work-related quality of life measure that we can look at, things like intention to quit, sickness, issues around workforce safety, bullying, harassment, and so on. Really exciting that we'll be able to do some work around this going forwards. I think in the future, there's a possibility of starting to look at care triads. There's been quite a bit of work led by Stacey Rand around care dyads, so looking at people using care and their informal carers. Now we can start to give a workforce perspective and look at the impact of interventions, policy changes on all three. And hopefully there's some potential for international use in the future, and it'll be great to hear people's views on that. Okay, next slide, please. So just some take-home messages before we close. I think what today's presentation and sort of looking back on what's several decades of work really is the importance of policy drivers on developing a tool like ASCOT. A lot of what we did was responding to those policy drivers, focus on outcomes, the personalisation agenda, the fact that we've got limited public resources and that we need to decide how those precious resources will be allocated to produce the best outcomes for individuals. That the development has depended on funding. We've had to access a huge amount of funding from different sources over the years to be able to undertake this long programme of work. And so many incredible research teams, too many to mention. I've name checked a few, but please don't be offended if we haven't name checked you. There are far too many people who have contributed enormously to this work that we have not been able to list all of the names. But people are listed on the publications on our website. So please do take a look at that. And of course, we couldn't have done any of it without the participation of people drawing on carer support, the care staff and the providers who have supported us by taking part in the studies, really influencing the direction of travel with ASCOT, which has been absolutely key. And I think, as Anne mentioned earlier, the sustainability and the relevance of a tool like ASCOT it depends upon things such as having a website, having resources so that people can go to navigate, access training, access information and videos. This takes time that isn't always easy to fund or support, because what we tend to do as researchers is do the bit of research, publish our results, move on to something else. But for something like ASCOT, which is such a big ongoing program of work, we've had to really think about how we overlay the funding, the time and the resources to allow us to continue to support it, and do things like this, this webinar. And partnerships with the sector, absolutely key. And a lot of the work that we're doing now, particularly around care planning, we wouldn't be able to do if we didn't have international partners working with us, such as Attendo and the Wooden Group. So yeah, huge thanks to them for driving this work forward. So I think that's everything from us. If you could go on to the next slide, just to point you to the resources, do take a look at that. We will be updating them soon because we've got these new exciting measures coming online. So there will be a bit of flux while we update some of those materials. But you can always come back to us if you've got any questions. Thank you so much for listening. I think we're going to stop recording and stop screen sharing, and we'll go over for a bit of a Q&A session now. Thanks, everyone.